Episode 25 Proximal Control Vascular Surgery Exam Prep. Vascular trauma, neck and upper limb, as well as lower limb trauma as a continuation of vascular trauma. FRCS and European Board Vascular Surgery Exam Focus Teaching. Welcome back to Proximal Control. I'm your host, Momia. This is the podcast where we prepare for the vascular exams the same way we practice as a day one consultant, with structure, judgment, and control. Because in vascular surgery, control is everything. Alright, welcome back to Proximal Control. This is a very high-yield revision episode as before on vascular trauma, and we will discuss about neck and upper limb trauma as well as lower limb trauma in this episode. So let's begin with neck trauma. Before vascular trauma in the neck, let's say this clear. The neck packs a number of vital structures into a very small space, and any injury can rapidly compromise those structures, importantly airway. Expanding hematomas can threaten the airway before they threaten circulation. In penetrating trauma, direct laryngeal or tracheal injury may override everything else. This is not a vascular chapter that ignores airway. There are two mechanisms again: the blunt trauma, which frequent but significant injury is relatively rare. Except for cervical spine injury, signs may be subtle. Index of suspicion is mandatory. Penetrating trauma, less common but far more likely to require surgical exploration. Gunshot wounds are more destructive than knife wounds, often transcervical, often involving multiple structures simultaneously. Blast injury combines blunt and penetrating mechanisms with heavy contamination. And a critical principle here is unnecessary CT angiography is a leading cause of treatment delay. Know when to scan and when to go straight to theater. So you need the hard signs of vascular injury in the neck. We have already discussed about the hard signs in the previous episode during the damage control surgery. In the context of neck trauma, we will say active arterial hemorrhage, expanding or pulsatile hematoma, palpable thrill, or audible bruit. Signs of distal ischemia, that is reduced GCS or neurology, suggesting stroke. Patients with expanding hematoma or active hemorrhage, they go immediately to the operating theater. Apply direct pressure to the bleeding site, but never probe blindly or apply blind clamps until you have operative exposure. Now, very important to know about the zones of the neck. The neck is divided into three zones, numbered cordocranially, bottom to top. Zone 1 from the clavicles and sternal notch to the cricoid cartilage. The structures at risk are thoracic outlet vasculature, that is subclavian arteries and veins, common carotid vessels, jugular veins, vertebral arteries plus trachea, esophagus, lung apex, thoracic duct, recurrent laryngeal nerve, vagus nerve, and phrenic nerves. Zone 2 from the cricoid to the angle of the mandible. This is the surgically important zone. Structures include the trachea, larynx, common, internal and external carotid arteries, vertebral arteries, jugular veins, esophagus, cervical spine, vagus, and hypoglossal nerve. Zone 3 from the angle of the mandible to the base of the skull. The structures included here are the extracranial ICA, ACA, and its branches, vertebral arteries, jugular veins, hypopharynx, and multiple cranial nerves such as facial, vagus, glossopharyngeal, accessory, hypoglossal, and the sympathetic chain. The anatomical landmark, very important to remember, the cricoid cartilage is equals to the C6 vertebral level, and that start the esophagus as well. Thyroid cartilage is the level of the C4. Hyoid bone is the level of the C3. The classical anterior and posterior triangle divisions is of little use in managing traumatic neck injury. Now let's talk about blunt cervical vascular injury and biffle grading. Motor vehicle accidents account for most blunt cervical vascular injuries. Other mechanisms are direct blow, violent rotation, hyperflexion, hyperextension, and worth knowing the chiropractic manipulation as well. So there may be no external signs at all. The incidence or the carotid injury is on 0.5% of all blunt trauma admissions. Vertebral artery injury up to 3 times more common than carotid. Overall cervical vascular injuries up to 1.55% of all blunt injury. So this is not very common as the penetrating injury. The high-risk patterns warranting investigation even without signs are severe cervical hyperextension, hyperflexion or rotation, especially with facial or mandibular fractures, near hanging with cervical anoxia, seatbelt sign on the anterior neck, cervical vertebral body fracture or dislocation, basilar skull fracture involving the carotid canal, closed head injury with diffuse axonal injury. The mechanism of arterial stretching causes endothelial tearing, producing intimal flaps, dissections, or emboli. The biffle grading of blunt cervical vascular injury based on angiographic appearance is grade 1 less than 25% luminal narrowing by intimal flap or intramural hematoma. Grade 2 is greater than 25% luminal narrowing. Grade 3 is false aneurysm. Grade 4 is occlusion. Grade 5, transection or hemodynamically significant injury. Critical exam point here is grade 1 to 3 may progress, so re-image at 7 to 10 days. Now the grade-based management, grade 1, as we said, less than 25% of luminal narrowing, and inaccessible grade 2, that is greater than 25% luminal narrowing, you consider anticoagulation to prevent thromboembolism and stroke. In grade 3, that is false aneurysm of internal carotid artery at skull base, you consider anticoagulation plus follow-up imaging. Stent if enlarging. So very important for the ICA pseudoaneurysm at skull base level. You do anticoagulation and follow-up imaging. However, you consider stent if on the follow-up imaging the pseudoaneurysm is increasing. Next is grade 4, that is the occlusion. The management is anticoagulation only. Grade 5 needs urgent operative treatment. Also accessible grade 2 and 3 needs operative management as well. Vertebral artery injuries, non-operative with anticoagulation, embolization for larger or distal lesions. Now let's talk about vessel-specific neck management in blunt trauma. What about common carotid artery? Injured by direct blow of common carotid artery may present with contralateral hemiparesis and diagnosed with CT angiogram, including intracranial carotids and circle of Willis. Internal carotid artery blunt injury occurs by rapid deceleration with neck rotation and hyperextension. The ICA is stretched over C2 and C3 transverse processes, causing intimal disruption. Classic presentation of contralateral hemiparesis plus Horner syndrome, particularly meiosis, from injury to sympathetic fibers alongside the distal ICA. Non-operative management of blunt carotid dissection. Anticoagulate with heparin where other injuries permit. Transition to warfarin or antiplatelet for 6 months. And again follow-up CTA in 1 to 2 weeks, and then according to regional or local protocol at 6 months. Operative management is reserved for common carotid artery and proximal ICA injuries. Interposition grafting, prosthetic or long saphenous vein is usually necessary as blunt dissection often extend distally, making primary repair impractical. Vertebral artery injury caused by flexion and rotation or cervical fractures, operative management is rarely necessary. Embolization, proximal and distal, is the endovascular option. Now let's talk about very important topic, the penetrating neck injury and zone-based management. The platysma is your decision point. Any wound must be assessed for platysmal breach. Breached platysma, operative intervention is generally indicated. Intact platysma, significant injury is unlikely. Modern CT angiogram has superseded all other imaging methods for assessing cervical vasculature in penetrating trauma. Zone-based management. Zone 1, root of the neck. The standard neck incision alone cannot achieve proximal vascular control. Hemodynamically stable patient should be imaged first. Median sternotomy is required for proximal control of the great vessels before the standard neck incision. Zone 2, the cricoid to angle of the mandible are amenable to surgical repair via the standard incision along the medial border of the sternocleidomastoid, and should be explored if platysma is breached. Extension Options are superiorly divide the digastric muscle, divide the ramus of the mandible, or dislocate the temporomandibular joint. Inferiorly, median sternotomy, laterally supraclavicular extension to the subclavian artery. Zone 3 is the angle of the mandible to skull base. Standard incision gives proximal control, but cranial extension is needed for distal control. So consider endovascular approaches for ICA and vertebral artery injuries in this region. Important caveat: the skin wound is not reliable guide to track of injury. Zones 1 and 3 are small. Flexibility is essential. Hemodynamically unstable patients with heart signs, immediate operative exploration. Stable patient, CT angio first. Now let's talk about the arterial repair in the neck, subclavian, and venous injuries. The surgical principles in neck arterial repair: debridement to healthy intima is mandatory before closure. Simple defects may be closed by lateral suture. Avoid significant luminal narrowing. Most injuries require patch angioplasty with long saphenous vein or prosthetic materials. Interposition grafting is more common than primary anastomosis. Unique neck option: the distal external carotid artery can be swung into the distal ICA to bridge the proximal ICA defect. What about the ICA repair versus ligation? This is often asked in the exam. The decision hinges on two factors. First, preoperative neurological status. No deficit means no significant focal ischemia and repair is safe. Major deficit means an ischemic area exists, so restoring flow may worsen status. Consider ligation. Second, back bleeding from distal ICA. Brisk back bleeding indicates good collateral flow, so favor repair. No back bleeding means flow interruption has already occurred and ischemic infarct is more likely. Ligation may be safer. So no back bleed, ligation. Major neurological deficit, ligation. Okay? Now, what about the subclavian artery injury? This may present with superior mediastinal hematoma, neck hematoma, or even hemothorax. Right subclavian in unstable patients, you need median sternotomy for proximal control. Left subclavian, more difficult. Its posterior position on the aortic arch may require division of the left brachiocephalic vein, a third intercostal space extension, or a trapdoor incision. The trapdoor carries a high incidence of postoperative neuropathic pain, so avoid it if at all possible. Now, distal control for subclavian extension: divide the sternocleidomastoid, platysma, strap muscles, and scalenus anterior. Preserve the phrenic nerve. Further distally via infraclavicular incision with clavicle division or removal. Distal control, supraclavicular extension. Divide the sternocleidomastoid, platysma, strap muscles, and scalenus anterior. And this will give you the supraclavicular extension to achieve the distal control. Very careful to preserve the phrenic nerve. If you need to go further distally, you can go via infraclavicular incision with clavicle division or removal. What about the repair options? Lateral arteriography, patch angioplasty, or interposition graft with PTFE or Dacron can be used. In proximal injuries, ligation blast site to end carotid subclavian bypass can be used. Hemodynamically stable with full CTA characterization, endovascular stent graft is a reasonable option. The pitfalls will be failure to achieve proximal control, risks exsanguination, always consider early median sternotomy. Subclavian injuries carry high rates of brachial plexus injury, so document neurological status pre and post operatively. What about the venous injury? IJV injuries can cause airway compromise due to hematomas. In shock, all venous injuries can be ligated. Where possible, repair IJV by lateral venography, patch venoplasty, or segmental resection and primary anastomosis. Anticoagulate post-repair. External jugular can be ligated. Air embolization is an overlooked danger. So nurse supine and head down, positive pressure ventilation on intubation can increase hemorrhage from large veins. Now let's talk about endovascular management in the neck trauma. Minor injuries under 50% narrowing tend to heal with anticoagulation alone. Stenting has utility for proximal subclavian injuries, distal ICA injuries due to anatomical accessibility. Larger false aneurysms of the distal ICA tend to enlarge. Placing a covered stent graft is a very good option. Post-stent dual antiplatelet therapy should be considered for 3 to 6 months, then single antiplatelet for life. Vertebral artery hemorrhage, proximal and distal embolization can be an option. Music here. Okay, now let's talk about upper limb vascular trauma. Delays in recognizing and treatment are the leading cause of preventable limb loss. The brachial artery is the most at risk and most commonly from penetrating trauma. The key numbers are blunt trauma, only 10 to 15% of all extremity vascular injuries. The penetrating up to 85% of upper limb vascular injuries. The brachial artery pressure index greater than 0.9 indicates no significant arterial injury. Brachial artery ligation amputation rate 24% versus femoral ligation limb loss 50%. So these are the two numbers that you need to remember. If you ligate the brachial artery, that means the amputation rate is 24% versus ligation of the femoral the limb loss rate is 50%. Unilateral artery dominant in 85% of patients, complete palmar arch in 90%. In penetrating forearm trauma, 60% have concomitant nerve injury. Single forearm vessel repair has a long-term patency only of 50%. Now let's talk about the ischemia time threshold. The nerves most sensitive, motor and sensory deficits after just few hours. Skeletal muscles 4 to 6 hours before reversible changes. Beyond 6 hours, irreversible damage increasing proportionally. The hard signs again for the upper limb is active hemorrhage, expanding or pulsatile hematoma, thrill or bruit, absent distal pulses, and very importantly the 5 Ps, that is pain, pallor, paresthesia, paralysis, and perishingly cold. The vessel-specific points, very important to know as well. For axillary artery divided into 3 parts by pectoralis minor, brachial plexus involved in 50% of penetrating injury of the axillary arteries, axillary vein involved in 40% of the axillary artery injury. Exposure is S-shaped incision from mid-clavicle following the deltopectoral groove to the biceps-triceps groove. Brachial artery, 20% of all arterial injuries. Ischemic consequences are greater proximal to the profunda brachii origin. Operative approach, groove between biceps and triceps, S-shaped curve at the joint crease. Forearm ulnar artery dominant in 85%, penetrating trauma, 60% have concomitant nerve injury. Injury to one of the 2 main arteries may be ligated, but early repair is preferable. Blunt orthopedic associations. Supracondylar humerus fracture injures the brachial artery. Clavicular fracture, subclavian or axillary artery. Shoulder dislocation injures axillary artery. So just to remember, clavicle fracture can injure both subclavian or axillary. Combined vascular and bone injuries sequencing. So you reperfuse first, place an arterial shunt before fracture realignment. Also shunt the injured vein before skeletal fixation. A shunted vein prolongs shunted arterial patency. So this is important. You try to put shunts in both artery and damaged veins if possible, and that should be done before the before the fracture realignment. Place shunts with enough redundancy to allow bone lengthening on realignment. Revise shunts to definitive interposition graft within 24 to 48 hours if fracture is already stable and out to length. Definitive vascular repair before fracture manipulation is important. Now let's talk about the MESA score, that is the Mangled Extremities Severity Score, and forearm compartment syndrome. There are 4 compartments with a clear threshold of amputation. The skeletal soft tissue injury, that is low energy stab, civilian gunshot wound, give you a score of 1. Medium energy open multiple fractures gives you a score of 2. High energy shotgun, high velocity gunshot wound or crush injury give you a score of 3. And very high energy with contamination gives you a score of 4. Limb ischemia, again another scoring point. Pulse reduced or absent with normal capillary refill gives you a score of 1. Pulseless with diminished refill 2. Cool, paralyzed, insensate gives 3. Double the ischemia score if the ischemia is more than 6 hours. Shock if the systolic more than 90 consistently, that score 0. Transient hypotension 1. Persistent hypotension gives you a score of 2. Age under 30 gives you 0. 30 to 51. Over 50 gives you a score of 2. Any mangled extremity severity score more or equals 7 is compatible with immediate amputation. MES less than 7, favor limb salvage. The MES is a guide, not a rule, so clinical judgment remains paramount here. The decision for immediate amputation requires at least 2 surgeons from different specialties. Now we talk about the forearm compartment syndrome, second only to the lower leg in frequency in trauma patients. Fractures account for 50% of cases. Very important exam point, presence of distal pulses does not rule out compartment syndrome. Absent pulse is a late sign. Compartment pressure more than 30 mm mercury require urgent fasciotomy. Symptomatic patients at 20 to 30 mm mercury also requires fasciotomies, especially in the multiply injured or persistently hypotensive patient. There are 3 forearm compartments. Volar compartment, that is wrist and finger flexors, ulnar and median nerves, most commonly affected. So remember that the flexors of the wrist and fingers are mostly affected, and the nerves that are affected is the median and ulnar nerves, and this is the volar compartment. Now dorsal compartment, that is the wrist and finger extensors and posterior interosseous nerve, is another compartment. Mobile ward, that is the brachioradialis, extensor carpi radialis longus and extensor carpi radialis brevis. So this is another compartment. So 3 forearm compartments: volar, dorsal and mobile ward. Mobile ward is the brachioradialis, ECRL and ECRB, that is extensor carpi radialis longus and brevis. Now the fasciotomy technique for forearm is something we often find difficult because we hardly do it. You do an incision in the skin and fascia over the volar compartment, carve across the wrist and elbow joint to avoid contracture. Include carpal tunnel release as a distal extension. Carve the wrist incision medially to avoid the radial artery. Proximal incision must be lateral to release the mobile ward. So the proximal incision goes a bit to the laterally, remember this, to release the lateral compartment, the mobile ward. Check dorsal compartment after volar release. If tense, straight dorsal incision between lateral epicondyle and wrist can access that. So remember to check the dorsal compartment after the volar release. If still tense, then straight dorsal incision between the lateral epicondyle and the wrist will release that compartment. Close fasciotomy at 3 to 5 days. Primary closure or split skin grafting can be considered. So remember to close on 3 to 5 days. Prophylactic fasciotomy is indicated for longer ischemia, more than 4 to 6 hours, combined arterial and venous injuries, or refractory shock and associated fractures. So these are the 4 groups where you consider prophylactic fasciotomy. Ischemia, longer, that is more than 4 to 6 hours, combined arterial and venous injuries, refractory shock, and associated fractures. The rule is prophylactic fasciotomy is always better than therapeutic fasciotomy when limb viability is in doubt. Okay, now we move on to the lower limb vascular trauma. In the UK, the vascular injury in 3 to 4% of trauma admissions and 38% involve extremities. Upper limb is more commonly injured than the lower limb, but lower limb carries higher mortality and higher perioperative complication rates. 56% is from blunt, and blunt trauma is worse functional outcomes and higher amputation rates. In military trauma, vascular trauma rate 10 to 12% and over 70% is extremity trauma. 2/3 are lower limbs in military trauma, predominantly penetrating. So these are 2 different mechanisms for civilian and military traumas. Let's talk about the pathophysiology. Indirect or lower energy wounds involve 1 or more layers without disturbing continuity. Direct or high energy wounds are more likely to transect or destroy the vessel. High velocity penetrating injuries greater than 2000 feet per second can also injure through cavitational energy, causing intimal disruption remote from the direct path. The vessel may look intact from the outside. It is not. The blunt force similarly dissipates kinetic energy through closed structures. Via closed fractures and dislocation. Intimal disruption with or without thrombosis in a macroscopically intact looking vessels can happen. Now let's talk about the injury classification. Laceration that could be full thickness tear with maintained continuity, mild less than 25%, moderate 26 to 50%, and severe more than 50% laceration. The transection, that is complete division, that severed ends retract and constrict, a physiological hemostatic mechanism as discussed earlier, pseudoaneurysms, that arterial wall disruption contained by adventitia or surrounding tissue, arteriovenous fistula, patent arteriovenous connection may be an early or late complication. Vessel contusion may be associated with flow-limiting intimal flap or dissection or a non-flow limiting subintimal hematoma. Music here. Let's now talk about the diagnosis and signs. So again, the hard signs mandate prompt surgical exploration. These include pulsatile bleeding, enlarging or pulsatile hematoma, pulse deficits, audible bruit, acute limb ischemia, palpable thrill. Any one of these is straight to the operating room. Soft signs require vascular assessment. These include non-expanding hematoma, proximity of the penetrating wound to a major axial vessel, specific orthopedic patterns, posterior to the knee dislocation, tibial plateau fracture, or displaced femur fracture. When soft signs are present, assess the Doppler signals distally, and this characterizes as a strong and bi or triphasic signals, then most likely it's normal, or a weak and monophasic signal, that means abnormal. The injured extremity index can be also used, the trauma equivalent of the ABI. That means the preferred term of IEI, that is injured extremity index instead of ABI. And this is preferred because it applies to both upper and lower limbs. It is the ratio to the highest occlusion pressure in the injured extremity divided by the occlusion pressure in an uninjured extremity. If it is more or equals to 0.9, that means it's normal and there is high negative predictive value for injury to the artery. No further imaging is required in most cases of more or equals 0.9, that is normal IEI, that is injured extremity index, which means normal versus abnormal extremity blood pressure. IEI less than 0.9 is abnormal, and this is sensitive indicator of a flow-limiting injury. In hypothermic or hypotensive patients, repeat the IEI 10 to 15 minutes after the resuscitation and warming. A persistently abnormal IEI even after repeating at 10 to 15 minutes warrants further imaging or direct operative exploration. In a prospective study of penetrating lower extremity injuries, the IEI had 100% positive predictive value and 98% negative predictive value in hemodynamically normal patients without orthopedic fractures. Now let's talk about the imaging. Duplex ultrasound with B-mode imaging with real hemodynamic velocity data is a non-invasive modality if immediately available. CT angiogram, the sensitivity is 90 to 100%, specificity greater than 90%, preferred over DSA, and can simultaneously evaluate head, chest, abdomen, and pelvis. DSA still has a role in polytrauma patients requiring immediate torso or head surgery, essential first step before any endovascular intervention. Then we say, okay, now we move on to the operative management of lower limb vascular trauma. Very important to know is the ischemic time. The neuromuscular ischemic threshold is less than 5 hours. As we previously said, it's better less than 4 hours under normal volumic conditions and less than 3 hours in hemorrhagic shock. This directly challenges the traditional 6 hours dogma. Remember, those numbers, they may come up because these are widely known, so you should know as well. General principles: if smaller arteries and veins distal to the popliteal level are often managed by ligation. Femoral and popliteal vessels generally require reconstruction. Tibial arteries supply the foot redundantly. Selective ligation is the default. Reconstruct only if all 3 tibial vessels are injured. So the operative reconstruction, there are 6 principles that you need to know. Wide operative exposure, proximal and distal control, thrombectomy, very important, Fogarty 4 or 5 French at femoral, 3 to 4 French at SFA or popliteal, and 2 to 3 French for tibial. Debridement of the injured vessels to the healthy intima, local or regional heparin, heparinized saline flush before and after vessel reconstruction, or ligation based on level and patient physiology. Let's talk about the femoral artery. Longitudinal incision from proximal to the inguinal ligament. Avoid superficial lymph nodes laterally and femoral nerve. The profunda femoris arises posteriorly and laterally. More than 1 deep femoral vessels may be present. Divide the lateral circumflex femoral vein covering the proximal profunda. Conduit of choice are reversed great saphenous vein from the contralateral limb. EPTFE or Dacron are expedient alternatives. So remember, the vein harvesting should be from the healthy contralateral limb. What about the SFA and popliteal? Mid-thigh approached medially with knee flexed and externally rotated. Reflex sartorius. Protect the long saphenous vein and the superficial femoral vein, which is nearly adherent to the artery throughout. At Hunter's canal, the SFA becomes popliteal. Here, the saphenous nerve moves from the deep to the superficial with the saphenous vein. The supreme geniculate arises the most distal SFA, dividing the adductor magnus fascia, exposes the distal SFA and proximal popliteal. So this is important to know that you have to divide the adductor magnus fascia to expose the distal SFA, and you also have to retract the sartorius, as you already said. Now, distal popliteal, you do medial leg incision 2 to 3 cm posterior to the tibia, 2 cm below the medial femoral condyle. The saphenous vein runs immediately under the skin here. Protect it. Posterior, retract the medial head of gastrocnemius and elements of soleus. Divide the proximal soleus from the tibia. The critical important bit at below knee level, the popliteal vein and tibial nerve overlie the popliteal artery. Separate with celastic vessel loops. For tibial outflow, selective thrombectomy with 2 to 3 French Fogarty catheters, heparinized saline flash, selective intratibial TPA 1 to 2 mg per vessel for residual thrombus, and this should be done with caution. Now let's talk about the venous injuries, shunts, fasciotomy, and the outcomes. The venous injuries comprise 51 to 60% lower extremity vascular trauma and virtually always coexist with arterial injury. Veins lack robust muscular media. Endothelial damage is localized to the laceration, unlike the artery, where injury extends proximally and distally. Generous debridement is therefore less critical for veins. Thrombectomy prefer manual milking over Fogarty catheters to protect venous valves. So this is another thing for the venous injury. Do not pass the Fogarty, rather you do manual milking to keep the valves intact. Repair technique with 4O or 5O monofilament, that is proline, for lateral venorrhaphy, vein patch for long lacerations, interposition grafts for transections, and autogenous vein is always preferred, ringed PTFE if size mismatch. Venous repair patency overall 73%, primary repair 76%, autogenous vein 66%. Surprisingly, PTFE is 73%. Axial vein ligation alongside arterial injury, you should perform 4-compartment fasciotomy to reduce compartment syndrome risk. So remember, if you have to ligate the vein, do prophylactic fasciotomy. Temporary vascular shunts, this is very important. Hollow plastic tubes inserted proximal and distal to the vascular disruptions to restore flow temporarily, less technical required than formal reconstruction, particularly valuable in the coagulopathic, acidotic, and hypotensive patients. That means in damage control situation. Military data, nearly 90% patency at femoral and popliteal level hours after placement and patient evacuation. Lower patency in distal vessels but did not preclude reconstruction. Techniques: debride edges, dissect 2 to 3 cm proximal and distal, insert no more than 2 cm into the vessel. Excess causes endothelial injury and thrombosis, so only 2 cm should be enough. Secure with 2-0 polyfilament such as silk up to 24 hours in situ without systemic anticoagulation. So you do not have to give any systemic heparin, and you can keep this shunt for up to 24 hours without any heparinization. Lower limb fasciotomy. If the compartment is more than 30 mm mercury, this is an absolute indication for 4-compartment fasciotomy, similarly as for the forearm fasciotomies, similarly as for the abdominal compartment syndrome, and you do decompressive laparotomy. The number is 30 mm mercury. So remember this number everywhere for fasciotomy or even decompressive laparotomies. Now, prophylactic fasciotomy strongly advocate for distal popliteal, anterior tibial, tibioperoneal trunk injuries, and any named venous injury. The data on delayed versus early fasciotomy is stark. Muscle excision rate 24% versus 11%, and the amputation rate is 31% versus 15%, mortality 19% versus 5%. So this is absolutely crucial that you consider early fasciotomies. The anterior compartment is most commonly affected and has the highest rate of inadequate decompression. This is very important to remember. Anterior compartment should always be decompressed. Deep posterior has the second highest, so this is often missed, but you cannot, now that this is another area to have muscle ischemia if you do not decompress. This is second to the anterior compartment, that is the deep posterior compartment, is important. Now, tactile confirmation. Palpate the lateral aspect of the tibia to confirm anterior compartment release. Palpate the medial aspect of the fibula to confirm the deep posterior compartment release. Okay, good. Now let's move on to anticoagulation. The absolute contraindication for anticoagulation is concomitant head injury. After arterial reconstruction, transition to antiplatelet therapy within 1 to 3 days are important. After axial vein repair, oral anticoagulation with warfarin for 3 to 6 months should be considered. So when you repair the veins, that needs to be anticoagulated, and arteries can be managed with antiplatelets. Now, mangled extremity and outcomes we already talked about. There's no scoring system has been validated for the limb salvage versus amputation decision. The clinical judgment, patient physiology, and patient preferences, all factors should be considered. Factors favoring primary amputation is mangled extremity with additional life-threatening injuries. And if there is a Gastillo type 3 fracture and circumferential soft tissue loss. These also may include extensive myonecrosis, tibial nerve transection, vascular injuries with prolonged ischemia, or inadequate bypass targets, inadequate distal bypass targets. Loss of patency within the first 30 days should be assumed. Technical in origin, urgent re-exploration is required. Always cover vascular grafts with vascularized tissue. Infected graft requires extra anatomical bypass to restore reperfusion while removing the infected conduit. Okay, now we are near to the end of this episode. Let's do some rapid take-home summary. Listen to it and memorize it. Neck zones, again, the caudocranial, that is zone 1, that's clavicles or sternal notch to cricoid cartilage. Zone 2, cricoid to angle of the mandible. Zone 3, angle of the mandible to the base of the skull. So it's caudocranial. Cricoid is at C6 level, and that starts of the esophagus as well. Thyroid notch is C4 and hyoid is C3 levels. The heart signs again at the neck, that's active hemorrhage, expanding pulsatile hematoma, thrill, bruit, reduced GCS or stroke is also a heart sign for the neck. Upper and lower limb, same plus absent and distal pulses. So in the upper and lower limb, same as the neck, in active hemorrhage, expanding pulsatile hematomas, thrill or bruit, plus the absent distal pulses, and 5 Ps, that is pain, pallor, paresthesia, paralysis, and peritoneally cold. This means actually 6 Ps because pulse less is also there, that is absent of distal pulse, so it's 6 Ps. And heart signs should directly go to theater. Biffle grading, as we said already, grade 1 is less than 25% narrowing, grade 2 is more than 25% narrowing, grade 3 is the false or pseudoaneurysm, grade 4 occlusion, and grade 5 is the transection. The reimage for grade 1 to 3 at 7 to 10 days, grade 1 and inaccessible grade 2, anticoagulate, grade 3 at skull base, anticoagulate plus minus stent, grade 5 and accessible grade 2 to 3, operate. Grade 5 and accessible grade 2 to 4, operate. Blunt carotid dissection, heparin, then antiplatelet or warfarin for 6 months, CTA at 1 to 2 weeks, and then 6 months. ICA repair versus ligation. If there is major deficit or no back bleeding, then you consider ligation. Now, penetrating neck trauma, platysma is the decision point. Zone 1, median sternotomy for proximal control. Zone 2, standard sternocleidomastoid incision plus minus extensions. Zone 3, endovascular and cranial extension. Trapdoor, high neuropathic pain risk, avoid if possible. Post-stent distal ICA, consider dual antiplatelet for 3 to 6 months and then single antiplatelet for life. Upper limb numbers, brachial, 20% of all arterial injuries, pressure index more or equals to 0.9, no significant injuries. And remember the pressure index that we discussed, IEI. Brachial ligation amputation is 24% versus femoral ligation 50%. So double than the brachial ligation. Ulnar dominant in 85% cases, complete palmar arch in 90%, penetrating forearm 60% concomitant nerve injury. Single forearm vessel patency 50% long term. Blunt injury 10 to 15% of extremity vascular trauma, and penetrating injury is 85% of upper limb vascular injuries. Now, combine vascular plus bony injury sequence. First, you shunt artery, shunt vein, then external fixation, then bring back in 24 to 48 hours after the patient is resuscitated and do the definitive repair with graft, definitive graft at 24 to 48 hours. MES score again, we talked about. The skeletal or soft tissue injury is 1 to 4. Ischemia, that gives you a score of 1 to 3. Double if the ischemia lasts more than 6 hours. Shock gives you 0 to 2 score. Age gives you 0 to 2 score. Overall score, if more or equals to 7, that is compatible with amputation. Score less than 7 favors salvage. So forearm compartment syndrome, another important thing to remember, second most common in trauma after lower leg. Fractures equals to 50% of cases, and pressure more than 30 needs urgent fasciotomy. 3 compartments, volar is the most common, dorsal, then mobile ward is the lateral. Include carpal tunnel release, close at 3 to 5 days. Distal pulse presence does not exclude compartment syndrome. In the lower limb section, vascular injury is 3 to 4% of the UK trauma admissions. Upper limb more commonly injured, but lower limb has higher mortality. Normal injured extremity index, that is more or equals to 0.9, is high negative predictive value to exclude injury of the blood vessels. Abnormal, that is less than 0.9, repeat after resuscitation, and if it is still less than 0.9, then imaging or surgery. Ischemia threshold less than 5 hours in normovalic patient and less than 3 hours in hemorrhagic shock, not 6 hours. So remember this for the importance of the lower extremity. This is not same as the upper extremity of 6 hours. So the numbers are 3 and 5, not 6. Okay. Now reconstruction rules. We already said FEMPOP, reconstruct, TVL, selective ligation, reconstruct only if all 3 vessels injured, conduit of choice, a reversed contralateral GSV, venous repair patency overall 73%, and autogenous vein graft has 66%, PTFE has 73%, and primary repair has the highest 76%. So surprisingly, PTFE has higher patency than autogenous vein graft in venous repair. Temporary shunts 90% patency at FEMPOP level, insert no more than 2 cm, secure with polyfilament such as 2-0 silk, up to 24 hours without systemic anticoagulation. Lower limb fasciotomy is mandatory again if it's more than 30 mm compartment pressure, prophylactic for high-risk injuries. Delayed fasciotomy, the risk of amputation mortality is higher. Confirm anterior compartment release by palpating lateral to tibia, confirm deep posterior by palpating medial to fibula. Now, infection always covers the graft with vascularized tissue, and infected graft you always consider extra anatomical bypass. Thank you very much. We are at the end of this episode. Thanks for listening to the Proximal Control Vascular Surgery Exam Prep. If you have found this useful, stay tuned, because in the next episode we will discuss more on vascular trauma. We will talk about the ESVS 2025 Vascular Trauma Guideline, very important topics for the written as well as the clinical and oral exams. And this guideline will summarize whatever we have discussed already about the vascular trauma, and this will be a very important episode coming on. We will also practice some relevant rapid-fire questions and clinical scenarios. As always, with your support, we will grow together. Keep listening to Proximal Control, because in vascular surgery, control is everything.